Well, it's 7, oh, or no, it's 2 o'clock. I'm sorry. I'm from overseas. Welcome all to our ASBMR clinical case workshop series, which we organized on behalf of the ASBMR Early Stage Investigator Committee. Today, we have Professor Dr. Naim Maalouf, international expert on the subject, and he will present together with Dr. Naveed Khanjee on the investigation and management of renal stones. Besides clinical cases, the recent literature will be discussed. Professor Dr. Naim Maalouf received his medical degree from the American University of Beirut in Lebanon and completed a residency in internal medicine at Emory University with a fellowship in endocrinology at University of Texas Southwestern. And he remained in this faculty at UT Southwestern and is currently professor of internal medicine. Professor Maalouf serves as Associate Director of the Charles and Jane Puck Center for Mineral Metabolism and Clinical Research and holds the Frederick Barter Professorship in Vitamin D Research. Dr. Maalouf's research and clinical interests include understanding the pathophysiology and improving the treatment of nephrolithiasis and also osteoporosis and pyrothyroid disorders. Dr. Naveed Khanjee is a second-year fellow in endocrinology, diabetes, and metabolism at the University of Texas Southwestern Medical Center. This session will be moderated by my colleagues, ESI committee members, Dr. Bruno Ferraz de Souza. He is endocrinologist at University of Sao Paulo in Brazil, together with ESI committee member Dr. Sabs Ramchand from Harvard University, USA. After the presentation, there will be a 15 or 20 minutes time slot for Q&A. So please use the Q&A tool for addressing your questions already during the presentation so that we have the time to get it organized. And now I'm very happy to hand over to Professor Dr. Naim Maalouf and Dr. Naveed Khanjee, please.
Thank you, Lisbeth, for this wonderful introduction. Are you able to see my first slide?
Yes.
Okay, perfect. I'd like to thank ASBMR for inviting us to present on this topic of nephrolithiasis. I have, in terms of disclosure, several NIH grants related to kidney stone disease, and my co-speaker, Dr. Khanjee, has no disclosures. And Naveed will start with a case of nephrolithiasis.
Okay, well, thank you all for joining. We have one presentation here. The chief complaint is a 52-year-old woman presents for the evaluation of recurrent kidney stones. So she first developed kidney stones in her 30s during her first 2 pregnancies, but this was minimally worked up and they resolved spontaneously. She remained stone-free until age 51. She presented with flank pain, nausea, and imaging showed a 4-millimeter ureteral stone. This was treated conservatively and the stone spontaneously passed. At this time, she hasn't had any stones since. She has no current symptoms related to stone disease. However, as she presents, she asks, kidney stone passage is worse than labor pain. What can I do to prevent more kidney stones? And before we get to a discussion on diagnosis and management, we can discuss briefly the epidemiology of kidney stone disease. And it's important to recognize that over the last 4 decades or so, we've seen a steady rise in the prevalence of kidney stone disease. And this is likely multifactorial, but one possible explanation can be seen as this rise correlates with rising obesity rates as well. There are several independent predictors of nephrolithiasis, some non-modifiable, including male gender, white race, obesity, diabetes, gout. However, we do see some changes in the epidemiology of kidney stone disease, including a narrowing of the gender gap and a faster rise in the rates of stone disease in Hispanics and Blacks. The medical burden of kidney stone disease in these patients likely goes beyond simply just having a stone, as these patients tend to have a higher incidence of CKD, cardiovascular disease, and fractures. And the burden for patients with kidney stones is also nicely illustrated by this slide, which shows that patients with multiple stone episodes are at higher risk of recurrent nephrolithiasis. So we see here that someone with one stone episode has about a 50% risk of recurrence at 30 years follow-up, but that risk progressively increases with multiple stone occurrences, as we can see here. And in the evaluation of nephrolithiasis, it's important to recognize that it's really less of a diagnosis and really more of a manifestation of underlying factors. So, unfortunately, even though there are often many specialists and providers helping to manage a patient's kidney stones, this management is often fragmented, with each specialist kind of focusing on their own specific component of the management. And it's really important to take a step back and evaluate a patient from a broader perspective.
So I'll take over here and we'll briefly review the proper investigation of a patient with recurrent nephrolithiasis, including how to get items on the history, what to look for on testing for blood, urine, and stone composition, imaging, and we sometimes recommend genetic testing for stone disease. And as far as management, we'll review data behind currently recommended lifestyle measures and pharmacological interventions. But in thinking of kidney stone management, it's also important to think about the pathogenesis of kidney stones, and it is definitely, in many cases, multifactorial. So there may be a genetic predisposition or a true genetic disease that either initiates or contributes to kidney stone formation. Several acquired metabolic factors can contribute to stone formation, including parathyroid disease or gut problems. And then dietary and lifestyle factors may modify the environment, the urinary environment, leading to crystal formation and growth of kidney stones. Finally, it's become more understood that there may be an abnormal epithelium that allows the initiation of a nidus on which a stone can grow over time. So with this in mind, one has to think broadly when approaching a patient with kidney stone, and starting with the stone composition. And this slide shows stone composition over a 10-year period in patients seen at our center. The most common stone type is calcium oxalate stones, almost three-quarters of the stones that are analyzed, followed by calcium phosphate. And then there's mixed stones, uric acid stones in red, and other rare types of stones in green. It's also important to appreciate that we've noticed an increase in obesity rates. And when we look at obese individuals who've had this stone analyzed at our center, there is a slight difference where there is a little bit more preponderance of uric acid stones compared to individuals with normal BMI. And that's at the expense of calcium phosphate stones and calcium oxalate stones. So one message is knowing what the stone type is important. And in obese individuals, uric acid stones tend to increase in prevalence. Now, let's focus on the three main stone types, and actually starting with calcium oxalate stones. The main pathogenesis is shown here. There is really the formation of calcium oxalate poorly soluble crystals that precipitate and form calcium oxalate stones over time. Now, the urinary environment also contains citrate, and citrate can form with calcium some soluble calcium citrate complexes, reducing the amount of free calcium to bind with oxalate. In addition to binding calcium, citrate can act as a direct inhibitor of crystals and can reduce formation of stones. There are promoters of calcium oxalate stone formation, including uric acid, but also other somewhat poorly understood inhibitors and other promoters of calcium oxalate stone formations. But in the end, with what we can measure in urine, some of the major urinary risk factors for calcium oxalate stones are a low urine volume, a low urine citrate, this major inhibitor of calcium stone formation, high urine calcium, high urine oxalate, and high urine uric acid. And these factors can be found either individually or in combination in a given patient. Calcium phosphate stones are the second most commonly encountered stone type, and they do have somewhat of a similar pathogenesis in that calcium phosphate is poorly soluble, and these crystals can precipitate, leading to calcium phosphate stone formation. Now, phosphate in the divalent form tend to occur more at the high urine pH. And that's why a high urine pH is a risk factor for calcium phosphate stones. Citrate is also an inhibitor and the binder of calcium with reducing calcium phosphate stone formation. And there are less well understood inhibitors and promoters of this factor. So in terms of urine risk factors in calcium phosphate stone formers, the major ones are low volume, low citrate, high calcium, high pH, and high phosphate. And then uric acid stones occur from a totally different standpoint. They happen whenever there is a low urine pH, which creates an abundance of free hydrogen ion that binds urate, and that leads to the precipitation of poorly soluble uric acid, leading to uric acid stone formation. And in many individuals, low pH is the major determinant of uric acid stones. And in that subpopulation, that happens because of insufficient buffering by ammonium, which is the main buffer in urine. So with that in mind, let's talk about the approach to investigating nephrolithiasis, and history plays a very important role, and that requires spending a few minutes asking patients about their stone disease and other risk factors. Some of the important parameters to ask is age at onset of stone disease, because a younger age may be more indicative of an underlying metabolic defect or a genetic component. Frequency of stone passage is important to guide the amount of therapy one wants to apply and the amount of tests one wants to do. We ask about the frequency of urinary tract infections, because those can predispose to stone formation, any past urological interventions, and whether there are any urinary tract abnormalities that can predispose to stasis and recurrent stone formation. Other conditions to consider are any condition that can lead to hypercalcemia, any history of gout and diabetes, any GI disease, any fracture history that may be relevant to the patient's care. The family history of nephrolithiasis is also important, but also understanding whether there was early CKD that may represent poorly understood nephrocalcinosis, or other endocrine disorders that may suggest MEN1, for example. Occupational history is important. Some patients are exposed to excessive heat and humidity in the summer because of their jobs, or some teachers, surgeons, or taxi drivers, for example, may avoid drinking fluids due to lack of bathroom break availability. I'll cover in more detail a dietary history that we take from our patients, but fluid intake and diet composition is relevant. And then we do ask about any prescribed and over-the-counter medications, both at the present and in the past. So that brings us to medications to ask about. Some medications directly crystallize in the urine and form stones by themselves. This is a minority of stones that we see, but other drugs can cause metabolic stones. Among the drugs that crystallize, triamterene is a commonly used potassium-sparing diuretic that can be seen in some stones, so important to look into that. Certain protease inhibitors used in the management of HIV are very insoluble and also good to ask about. And then some over-the-counter medications such as guaifenesin and ephedrine can crystallize directly. That's why we ask about over-the-counter supplements. Certain drugs that cause metabolic stones are shown here. So carbonic anhydrase inhibitors such as acetazolamide and topiramate can lead to high urine calcium, low urine citrate, and high pH, predisposing to calcium stones. Many patients with osteoporosis take calcium and vitamin D supplements that could predispose to hypercalciuria and calcium stones again. Some patients use uricosuric agents either for gout or for other reasons, and that can increase urine uric acid. And that's a risk factor for both calciumoxalate stones and for uric acid stones. During the COVID-19 pandemic, we've seen a lot of patients taking high doses of vitamin C, and vitamin C can lead to kidney stone formation because it is metabolized in the body to oxalate. And vitamin C intakes of greater than 1 gram per day is a risk factor for calcium oxalate stone formation. Finally, in the field of osteoporosis, we use PTH analogs frequently for the management, and these drugs can lead to hypercalciuria, predisposing to calcium stones. As far as diet, here I'm showing the urinary risk factors that we look for and which dietary determinants can contribute to stone formation. So a low urine volume from low fluid intake or excessive diarrhea can predispose to concentrated urine and be a risk factor for all stone types that we see. High urine calcium can happen from too much calcium intake or also from excessive salt intake or protein intake, and hypercalciuria is a risk factor for calcium stones. We mentioned citrate as an inhibitor of calcium stones, and we do see low citrate in patients who take excessive animal protein or have a low alkali intake, and one can think of citrate as a marker of acid-base balance. High oxalate intake high urine oxalate can happen from low calcium intake or high intake of oxalate precursors or vitamin C, like we mentioned. And this is a risk factor for calcium oxalate stones. A diet that's too alkaline in nature may lead to high urine pH and predispose to calcium phosphate stones. On the other hand, a diet that's rich in protein and low in alkali intake predisposes to low urine pH and uric acid stones. And then finally, excessive intake of protein or purines is a risk factor for hyperuricuria, which can lead to calcium oxalate and uric acid stones. When thinking of tests that we order for our stone formers, we get on a routine basis a complete metabolic profile, including measurements of phosphorus and uric acid. And some clues in the diagnosis could come from the blood tests. So for example, a low serum bicarb and a low serum potassium may be an indication of either renal tubular acidosis or of chronic diarrhea. If one sees a low serum phosphorus and a high serum calcium, that could be a clue for primary hyperparathyroidism. High serum creatinine may be a sign that we are dealing with a congenital condition that's accelerating stone growth and kidney function loss. And then high uric acid could indicate gout. Stone analysis, in my mind, is very essential in directing the care of patients, but unfortunately is underutilized. And we encourage patients to try to catch their stone by straining their urine. Urinalysis, including microscopy, could be helpful. Some crystals in the urine are very pathognomonic for stone disease, especially for cystine stone. That's a rare stone type, but can be diagnosed starting with a crystal analysis. Hematuria on urinalysis can be helpful. You may find signs of UTIs. And I put a question mark around pH on the urinalysis because that's generally measured by dipstick, and that's very dependent on the observer. That's why we recommend looking at pH on a 24-hour urine rather than on urinalysis. Now, getting a 24-hour urine measurement can appear as a cumbersome endeavor, but that's not necessarily so. Many stone formers indicate that they would be interested in collecting a 24-hour urine, but it's their physician who never offers them to do that type of testing. Now, 24-hour urine collection may not be required for all stone formers, but we definitely recommend it for those with recurrent stones or individuals who are first-time stone formers but are at high risk for stone recurrence. And by high risk, I mean patients who have a strong family history, those who are younger, those who have any stone component other than calcium oxalate. Imaging is essential for assessing stone burden, but also to look for nephrocalcinosis. And it's well recognized that CT scan is the most sensitive and specific way to diagnose kidney stone formation, but a CT scan does involve radiation. And that's why KUB is still occasionally used in the follow-up of stone formers. But ultrasound and MRIs, I would say ultrasound more than MRI is what's recommended in pregnant individuals as well as in children. And then finally, genetic testing. There is now stone panels that could be ordered. I would reserve those to patients who present with stone disease at a younger age, those who have a family history of stone disease, those who have CKD at the same time as their stone disease, or if they have nephrocalcinosis, or extreme abnormalities on their 24-hour urine tests. And I'll be happy to cover more of that during the question and answer session if there's any interest. So that brings us back to this question of pathogenesis of nephrolithiasis and how much of stone disease is due to changes in the environment versus genetics. And I have to say that twin studies and other genetic studies done primarily in the 1980s and early 90s have suggested that heritability of stone disease is around 50%. So 50% of stones are due to abnormalities in genetics, and 50% are due to environmental factors. But as Naveed indicated, there's been a almost doubling of stone incidence in the past 40 years. And clearly the genetic pool has not changed over that time frame. So I really think that over time, environment has become a more important factor in explaining the increase in stone prevalence. Now, environment involves many things. Individuals in the society tend to have more protein than 50 years ago, more salt intake, less fluid intake, heat or temperature changes in global warming has been also suggested to contribute to the increase in the prevalence of stone disease. We also are seeing greater use of antibiotics, which could alter gut microbiome, and that's been linked to stone disease as well. And then finally, there is improved diagnostics, increased imaging, and some patients are being diagnosed with stone disease incidentally on imaging studies. So this 50-50 heritability versus environment, which was true 40 years ago, I think is less true, and it may be 60-40 or maybe even more towards environment at this time. But that's a good thing because that's something we may be able to target in our patients. Now we come back to the case that Naveed presented earlier today.
Thank you. So we'll go over a little bit more about her just past medical history. She has osteopenia by DEXA scan. She has a low frax. She has no significant past surgeries. At this time, she's not complaining of any significant symptoms related to stones, no hematuria, dysuria, any symptoms suggestive of a UTI. There's no chronic diarrhea or gastrointestinal disease. There's no history of fractures or musculoskeletal pain, no history of gout or diabetes. Her father does have a history of kidney stones, which suggests a possible genetic component to her stone disease, but there's no family history of osteoporosis or prior hip fractures. She doesn't smoke, she does not drink alcohol, there's no other drug use. She exercises a moderate amount, doing cardio or weightlifting 2 to 3 times a week. Her only medications at her initial evaluation is calcium, 600 milligrams a day, and then 5,000 units a day of vitamin D. And on physical, really an unremarkable physical exam and a normal BMI. So her initial lab work also is relatively unremarkable, at least from a serum perspective. Serum calcium, creatinine, GFR, PTH, all normal. Phosphorus, magnesium, and her vitamin D levels were all in the normal range as well. And really the rest of her CMP was unremarkable. And we did get some imaging, and her renal ultrasound did not show any obvious renal stones. Before she came to us, she did have a 24-hour urine collection done at an outside facility. And on that urine collection, she was taking the calcium and vitamin D. And really the only remarkable component to that was a urine calcium level of 365, which was elevated. After she came to us, we repeated a 24-hour urine collection, and that one had a slightly lower urine volume. And this was off of medications. She had been taken off for the calcium and vitamin D at that time, but her urine calcium level remained elevated at 345. And then notably, you can see the rest of her urine studies, and her uric acid levels were normal. Everything else was really in the normal range for her.
So our patient had hypercalciuria, and this is the most common abnormality that's found in kidney stone formers. And the most common causes of hypercalciuria are shown here. The one common one that we should not forget about is primary hyperparathyroidism. In fact, kidney stone is nowadays the only symptom of primary hyperparathyroidism in some patients. And in primary hyperparathyroidism, the source of excess calcium in the urine is several. There is increased GI absorption from greater 125D production from enhanced PTH secretion. There is some component of calcium coming out of bones from high PTH. And then there's also renal sources, because in the face of hypercalcemia, the calcium sensing receptor leads to greater urine calcium losses. Some of the key laboratory findings, as many of you know, is increased serum calcium and PTH, and the treatment in a stone former would be parathyroidectomy. Another entity that's also associated with high serum PTH is something called the renal leak of calcium. And here really the abnormality is at the level of the kidney. As the name implies, there is a renal leak, possibly from abnormalities in some of the transporters involved in calcium reabsorption. Now, this renal leak leads to a tendency for lower serum calcium, either frankly low or low normal serum calcium. And then there is secondary hyperparathyroidism in those patients. And here, treating with a thiazide diuretic helps with calcium retention and many times corrects the PTH elevation. And that's one differentiating factor between primary hyperparathyroidism and a renal leak of calcium. Some dietary factors that lead to hypercalciuria are excessive salt and protein intake. Now, sodium reabsorption is closely linked to calcium reabsorption, and that's why in salt abuse there is excessive renal leak of calcium. Here, one key finding is a high 24-hour urine sodium, and really the treatment would be salt restriction. And high protein intake may lead to hypercalciuria through many different mechanisms. High protein intake can directly increase GI calcium absorption. There may be greater filtration of calcium due to increased GFR, and there may be a component of bone loss because of the acid load that's imparted by the excessive protein intake. One key laboratory finding to diagnose high protein intake is again on a 24-hour urine measuring urea or sulfate. Both are markers of animal protein intake, and here protein restriction alone could lower urine calcium in your patient. Some less common causes of hypercalciuria are shown here. So some patients have CYP24A mutation. This is mutations in the gene encoding the 24-hydroxylase enzyme that breaks down 125-dihydroxyvitamin D. And because of these mutations, there is high 125D, which can lead to either high normal or frankly elevated serum calcium. That's from excessive absorption of calcium. One key laboratory finding is a high ratio of 24-25-hydroxyvitamin D to 25D. And then here the treatment would be vitamin D restriction and ketoconazole. I'm sorry, this ratio should be 25 over 24-25. Granulomatous disorders can also increase 125D by causing sometimes frank hypercalcemia, but occasionally normal calcium, increasing gut absorption. And the treatment is to address the underlying disease. So if it's sarcoidosis, maybe giving prednisone. If it's a lymphoma, treating the lymphoma itself. And then some high bone turnover states can lead to hypercalciuria. For example, in Paget's disease of the bone, there could be excessive bone resorption, can be detected by bone resorption marker, and treating the excessive bone turnover can lower urine calcium. And then finally, many patients have what we call idiopathic hypercalciuria that is in general absorptive in nature. So there's excessive GI absorption. Those patients tend to have normal serum calcium and PTH. About 2/3 would have a high 125D, a third would have a normal 125D. And here treating with thiazides tend to correct the hypercalciuria. So our patient had hypercalciuria. We did rule out many of the abnormalities that I described previously, and we think she has idiopathic hypercalciuria that's probably inherited. And so in terms of discussing with her how to prevent stone recurrence as she requested, we can start with lifestyle modification, and then we can discuss pharmacological therapy. Fluid intake is an underused resource for stone prevention, and it's really very effective, low risk, and inexpensive intervention that can be very effective. In the only randomized trial of adults with urinary stones, increasing fluid intake to maintain urine volume greater than 2 liters per day was able to decrease stone recurrence by 55%. However, in clinical practice, many stone formers are unable to maintain this high urine output. And in fact, we have recently finished recruiting for the PUSH study. This is a prevention of urinary stone with hydration study. This is an intervention trial really looking to alter behavior to maintain high fluid intake. Calcium intake and nephrolithiasis is a very important topic, especially in our patient who had osteopenia. So here, it's important to think about calcium intake in terms of diet versus supplements. And 30 years ago or so, we used to think that reducing calcium intake is important in our stone formers. However, this first study challenged that concept. This was an observational study, the Nurses' Health Study 1, in which 92,000 women aged 34 to 59 were followed for 12 years. And in that follow-up time, there were 864 incident kidney stones. Now, the investigators then looked at calcium incidence, stone incidence based on quintile of dietary calcium intake. So the lowest dietary calcium intake, in this case, less than 400 milligrams per day, versus increase in quintiles to greater than 1,000 milligrams per day is shown here. And with increasing quintiles, there is a decrease in the relative risk for new stone formation. Or thinking about it, we do not want to restrict calcium intake in our stone formers because of the risk of greater stone recurrence. On the other hand, supplemental calcium behaves a little differently. This is the largest randomized clinical trial of calcium supplementation versus placebo. This is the Women's Health Initiative Calcium ND trial, in which 36,000 women who at baseline already had on average 1,000 milligrams of calcium per day were randomized to either placebo or 1,000 milligrams per day of calcium carbonate and 400 units of vitamin D3 daily. And over the 8 years of follow-up, the participants who received calcium ND had an increased incidence of stones with a hazard ratio of 1.17 or 17% greater stone incidence. That's why it's important to be aware of using calcium from supplements in our stone formers. Now, this was with calcium carbonate. However, calcium citrate may not raise the risk of kidney stone disease to the same extent. And this is because calcium citrate may lower urine oxalate, as well as provide citrate, which is an inhibitor of stone disease. Another study that also cemented the avoidance of a low calcium diet is shown here. This was published 20 years ago in the New England Journal of Medicine. In this study, calciumoxalate stone formers were randomized to either a low calcium diet or to a normal calcium but low protein, low salt diet. And over the 5 years of follow-up, participants who took the normal calcium diet had significantly lower incidence of stone recurrence than going on a low calcium diet. These two arms had similar urine calcium, but the normal calcium arm ended up having lower oxalate, and that's probably because of normal calcium intake binding oxalate in the gut. So with this in mind, when faced with a stone former, when I discuss calcium intake, I recommend really a normal calcium diet for patients with stone disease. And I tell them that the preferred source of calcium is dietary sources rather than pills. However, some patients have lactose intolerance or are unable to get enough calcium from their diet. And in those patients, I recommend using calcium citrate over calcium carbonate, primarily because of the greater rise in urine citrate, but also because you could use smaller intakes of calcium from calcium citrate than carbonate. Also, if I have to use calcium pills, I recommend that those are taken with meals rather than on an empty stomach, and this is to bind oxalate. And finally, I do remeasure calcium oxalate citrate after adding calcium. A closely related topic is what to do about vitamin D supplementation in stone formers. And here I counsel my patients that a serum 25 hydroxyvitamin D greater than 40 nanograms per ml has not been shown to be helpful for any bone or other non-calciotropic outcomes. So I tend to be conservative and push for serum 25D between 30 and 40 nanograms per ml in my stone formers. There are some few studies that have looked at vitamin D supplementation in doses less than 2,000 units per day, in which there was a minimal change in 24-hour urine calcium. However, I do keep in mind that some stone formers may be more sensitive to the effects of vitamin D, and some stone formers may be developing a greater increase in 125D or in their urine calcium upon vitamin D supplementation. Some of these subgroups are patients with primary hyperparathyroidism, those with 24-hydroxylase deficiency, those with mutations in CYP34A1, that's a mutation that can raise 125D, and then sarcoidosis or other granulomatous disorders. And again, if I'm going to use vitamin D supplementation, I would remeasure serum 25D and urine calcium just to make sure it's not rising too rapidly with vitamin D supplementation. Another lifestyle measure that can be helpful is increasing intake of citrus fruit juices, and particularly orange juice. In this study, normal volunteers and stone formers were studied at 3 different times while eating the same diet, but with drinking different fluids, one phase with water, one with lemonade, and one with orange juice. And of the 3 fluids, orange juice was the one that increased urine citrate the most. And if you recall, citrate in the urine is an inhibitor of stone formation. Many stone formers are told to drink lemonade or add lemon to their water. There is no harm in doing that, but I would counsel more for orange juice over lemonade. So how cost-effective is lifestyle modification for stone formers? In first-time calciumoxalate stone formers, lifestyle modification is cost-effective and very efficacious at reducing stone recurrence. But if one is dealing with a recurrent calciumoxalate stone former or with uric acid stone former or other stone types, conservative therapy is really unsatisfactory despite the low cost because there's more recurrence rates. There's also cost effectiveness studies to show that there are cost savings from medical management of stone disease by reducing the amount of surgeries these patients require. So for our stone former who had 3 stones already, I'm going to consider pharmacological therapy if her lifestyle modification is not sufficient. And the first agent to consider are thiazide diuretics. These specifically lower urine calcium excretion by increasing reabsorption of calcium from the urine into the blood. This is one clinical trial in calciumoxalate stone formers who were randomly assigned to either placebo or chlorthalidone at 50 or 25 milligrams per day and followed for 36 months. One can appreciate that over that time frame, getting chlorthalidone at either dose reduced the risk of recurrence significantly. Another pharmacological therapy for calcium stone formers, and here specifically in those with high urine uric acid, would be to use allopurinol. Like I mentioned at the beginning, uric acid is a promoter for calcium oxalate stone formation. And in calcium oxalate stone formers, giving allopurinol significantly reduces stone recurrence over 3 years compared to giving those stone formers placebo. So that's an option for hyperuricosuric stone formers. And then finally, potassium citrate is a form of alkali that can also reduce recurrence of stone disease. Specifically here shown is calcium stones, but also this is applicable to uric acid stones. Again, over 36 months of follow-up, potassium citrate use significantly reduces recurrence rates. So this is how I end up approaching pharmacological therapy for calcium stone formers. I start by looking at urine calcium, and if it's high, then I would add a thiazide diuretic, either chlorthalidone or hydrochlorothiazide at higher doses than what is used for hypertension, and those patients frequently need potassium supplementation. If the patient is not hypercalciuric, but they're hyperuricosuric, I would use allopurinol. And if they're neither hypercalciuric nor hyperuricosuric, one can use potassium citrate to raise citrate and reduce stone recurrence. So with this background in mind, we're coming back to our patient here.
Yeah, so we left this patient in May 2019, noticing that she still had an elevated urine calcium. At that point, she was initiated on chlorthalidone, relatively low dose, 12.5 milligrams a day. We did notice an improvement in her urine calcium, and the dose was then subsequently increased over the next several months, which led to resolution of her hypercalciuria. All of her other urine parameters stayed relatively stable during this time.
So our patient had also osteopenia, if you recall, and it's important to keep some factors in mind when counseling patients with osteoporosis or osteopenia and stone disease. And here, there is now substantial epidemiologic studies that have suggested that kidney stone formers are at higher risk for fracture, but also low bone density. This reference here is a meta-analysis of several large studies, if you're interested in looking into that. Now, what are the mechanisms for greater fracture risk in stone formers? I don't know that there is a single mechanism. There may be some shared genetics between osteoporosis and nephrolithiasis. So for example, we know that both conditions are more common in Caucasian individuals, but also certain genes have appeared in GWAS studies for both osteoporosis and nephrolithiasis, and I'm showing some of them here. There may be some common acquired risk factors. So primary hyperparathyroidism can lead to both stone and bone disease. Patients who have bowel disease, chronic diarrhea may have calcium and D malabsorption leading to bone disease, but also to enteric hyperoxaluria. Chronic kidney disease is a risk factor for both stones and bone health. Diabetes is a risk factor for both stone disease and greater fracture risk, possibly independent of bone density. And then some patients have distal renal tubular acidosis, and this condition predisposes to both stones and bone disease. Certain dietary parameters can increase the risk of stone and bone disease, including high sodium, excessive protein intake, and also a low calcium diet. And then finally, high 125D at very high doses can lead to bone resorption and hypercalciuria and stone disease. In terms of management, we still focus on the same diet, which is a normal calcium, low salt, moderate protein diet for our stone formers and patients with osteoporosis. And then when thinking of pharmacological therapy, like we said, if we're going to use calcium supplements, use them with meals and use calcium citrate, use vitamin D in moderation, specifically in certain subsets. And then thiazides and potassium citrate have been shown to improve bone density in stone formers. So they may have some relevance for osteopenia. Bisphosphonate use has been also shown to lower urine calcium in some patients with nephrolithiasis. So here I would like to summarize what we discussed today. In terms of investigation of nephrolithiasis, it's important to take a detailed history regarding stone disease, regarding diet, as well as other medical and surgical history to guide management. Looking at stone analysis, calcium oxalate is by far the most common, but uric acid is increasingly noticed among obese stone formers. Urine testing is very helpful, and now many large laboratories, companies in the US as well as abroad, can offer a 24-hour stone risk profile that can be easily done by the patients. Blood testing, we talked about electrolytes, calcium, phosphorus, uric acid, etc. Imaging is helpful not just for assessing stone burden, but also following patients over time, nephrocalcinosis. We have several modalities available. And then finally, in terms of management, we do look at the stone type and the urine risk factors on a 24-hour urine. So like we talked about, certain risk factors are shared among stone types, and we do have increasing fluid intake as a mitigating lifestyle modification for all stone types. There is increasing interest in the SGLT2 inhibitors to increase urine volume, but that's not been studied completely for stone disease. In patients with high urine calcium, which is a risk factor for calcium stones, low salt and low protein normal calcium diet is helpful. Thiazides and potassium citrate are good pharmacological intervention. Those with low citrate, we use potassium citrate, but also reduce protein and increase alkali intake for diet. For hyperoxaluria, we recommend taking calcium with meals, reducing oxalate intake and vitamin C intake. I didn't touch too much on it, but last year the FDA approved one new medication called lumasiran for a specific subset of patients with hyperoxaluria, those with primary hyperoxaluria type 1 or PH1. That's a rare subset, but it's still encouraging to see a new medication for stone disease. There are medications that can alter urine pH, and then for high urine uric acid, which is a risk factor for both calciumoxalate and uric acid stones, again, a low protein, low purine diet is helpful, and allopurinol may be used pharmacologically. I'll end here, and Naveed and I will be happy to take any questions.
Thank you so much, Dr. Maalouf, for this wonderful presentation. Thank you, Naveed, as well. I think the case was very rich and promoted all this discussion, and we learned a lot from you. We have received several questions already, and I'm going to try to divide the time between Sebs and I. So I'm going to put my timer on for 6 minutes. And the first question I'm going to make, Dr. Maalouf, has to do with drugs that might increase the risk for hypercalciuria, as been asked by our audience. So people have asked about furosemide and SGLT2 inhibitors. So could you comment on that?
Yes, definitely. That's an excellent question. So furosemide clearly increases urine calcium excretion, especially early on when furosemide is started. In a steady state, it does urine calcium does stay a little bit higher chronically, but it's the acute setting where you may see a higher urine calcium excretion. And I have to say the same thing applies to SGLT2 inhibitors. So those agents clearly work by reducing sodium and glucose reabsorption. But in a steady state, one cannot be losing sodium chronically. Otherwise, the body weight will continue to decrease and decrease and decrease. So acutely, there is a rise in urine sodium, which is coupled with a rise in urine calcium. But in a steady state, urine calcium and sodium tend to go back to baseline with those agents.
Brilliant. And still with the effects of drugs, there's a question about, in your experience, how many percent of patients, just moved, with hyperabsorptive hypercalciuria become hypercalcemic when they start a thiazide diuretic?
So I would say for sure a good proportion, 10 to 20%. This is somewhat dependent on the dose of thiazide that is used. The higher the dose, of course, the higher the serum calcium. And I definitely warn my patients that we are likely to see a higher serum calcium after we start thiazide. So let's not panic about that. Let's not assume that it's primary hyperparathyroidism. So before I start the thiazide, I tend to first rule out primary hyperparathyroidism or hypercalcemic causes, and then I feel more comfortable starting a thiazide.
All right. So this question mentioned hyperabsorption as a mechanism of hypercalciuria, and we received a question through the chat too that touches on that. And I don't know if either Naveed or yourself want to comment on it. The question was about if the fasting calcium to creatinine ratio was measured in that patient to exclude renal leak, and if you use that to exclude renal leak or not.
Yes, I'm happy to take that question. So in interested patients, we still do more detailed testing of hypercalciuria, meaning we measure fasting urine calcium, and we sometimes give them a calcium load and measure calcium in urine calcium excretion post-load. That's one way to divide fasting from post-absorptive hypercalciuria. This specific patient was not interested in undergoing more testing. So we did not go that way. But the other important thing to keep in mind is that both conditions, fasting and renal leak and absorptive, would be treated with a thiazide diuretic. So as far as management, it would be more or less similar.
Great. And if you could expand a bit, I have a frequent scenario when I want to use a thiazide, but the person is thin and doesn't tolerate the dose, and then has low blood pressure. How do you go about that? What can you do to titrate the dose, etc.?
That's another good question. And we usually start on a lower dose, even though that's not as effective. We try a lower dose to see what is the patient's tolerance. The other important medication for individuals with low blood pressure is potassium citrate or alkali therapy. That also lowers urine calcium excretion, and I feel is underused because it can lower urine calcium by 40 milligrams per day or 1 millimole per day, and that can make a big difference.
Great. And in that scenario, if it's a person that has a low dietary calcium intake, would it be the same to use calcium citrate instead of potassium citrate? Is there a difference in effect?
So the urine citrate increases more with potassium citrate than with calcium citrate. So that would be the advantage of using potassium citrate.
Perfect. I'll go to another question from the chat, and then I have another question for myself before my time runs. So there's a question about if there's a limit to the dose of calcium citrate supplement that you would use if a patient has osteoporosis and they don't get from. So would you stop somewhere? Like say it's a person that has no intake from diet. Would you go to 1,000 or more?
Yeah, in general, we still follow the recommended daily allowance, which in the US is 1,200 milligrams per day. Now, I occasionally use 1,000 milligrams per day because there may be some calcium intake from other sources that we don't count in the diet. So I would say 1,000, a maximum of 1,200 milligrams per day. And I try to divide it throughout the day rather than all at once.
Brilliant. Two quick questions from me. I just wanted to ask you about the definition of hypercalciuria. I saw that you use the daily, more than 250 milligrams. I wonder if you use other forms, say per weight, more than 4 milligrams per kilo, or other ways that are proposed, because there's a lot of conflict in the literature. And the other one is, how far do you go in the investigation of asymptomatic nephrolithiasis? So someone who has never had a crisis and finds calculi on let's say a TC ultrasound, do we have to do all this investigation? How do we do?
So to answer the second question first, you don't absolutely have to investigate further. I mean, I would look at stone size. I also, if the patient has osteoporosis, I may do a urine calcium measurement for sure, because we may be identifying an abnormality that could be targeted. And then occasionally some patients are identified because they are interested in donating their kidney to a relative, and then the CT scan is obtained and you see a stone, and in that case I would investigate further for stone donation. But in a, let's say, 2 millimeter stone seen on a routine abdominal imaging, if there is no history of clinical stones, you don't absolutely have to go with a urine collection, etc.
Brilliant. And anything about the urinary calcium?
Yes. So people have, so there are multiple definitions. One of them is more than 250 milligrams per day. Some people would use 250 in women and 300 in men. Some people use 4 milligram per kilogram per day. Unfortunately, none of these have been directly looked at to see what predicts stone incidence, for example, or fracture incidence. But I do keep in mind the patient's weight. Now, obese individuals do have higher body weight, higher urine calcium excretion, but also more stones. So even if they're extremely obese, and I don't use just that 4 milligram per kilogram, I do worry about the absolute value.
Thank you so much. I'll hand it over now to Sebs to continue with the questions.
Great, thanks. I'm going to try and speed through some of these because I realize we have a few minutes left and there are a lot of questions. I will ask you one quick question about protein. So how much protein would you advise for someone for a low protein diet?
Yeah, so again, the recommended daily allowance for protein intake is around 0.8 gram per kilogram body weight per day. So the lowest amount that would be compatible with good health is 0.8 gram per kilogram per day. Roughly, you could say 1 gram per kilogram per day is a good amount.
Okay. And can you use a spot urine instead of 24-hour collection?
So spot urine is not very good because urine calcium changes if you're measuring it before or after a meal. So I really reserve a spot urine in patients who cannot collect a 24-hour urine, like children. But other than that, I really find very little utility in spot urine.
And if you are going to use it, then with the timing of the day, what would you advise? If fasting state, fasting in the morning, or?
Yeah, so fasting would be better if I'm going to use it because there is well-defined normative ranges. Postprandially, it really will vary based on what the patient eats, and that can be extremely variable. So.
Okay. There's a question here about the case directly. Victor Schneider wonders if the patient's hypercalciuria and resolution could be caused by the vitamin intake of 50,000 units a day.
Naveed, do you want to take that?
Yeah, well, so just to be clear, she wasn't taking 50,000 units a day. She was taking 5,000 units a day. But I believe that even off of that medication, she was still hypercalciuric. I believe she dropped like maybe 20 milligrams per day from 365 to 345, even off of the vitamin D. And so we really think that the chlorthalidone was probably the driver in the improvement.
Thanks. This is a question about thiazide therapy again. It talks about thiazide therapy for hypercalciuria. If you are starting thiazide therapy, what time frame do you allow before repeating the urine calcium? And then how much time do you allow for the bone density to improve with thiazides before considering osteoporosis therapy?
Sure. So I would repeat the 24-hour urine 3 months after initiation of thiazide diuretics, I think, for measuring urine calcium. As far as bone density, it's unlikely to change very quickly. So in large trials where people have looked at changes in bone density with thiazides, in groups of patients, the bone density starts to improve at 1 year. But in an individual patient, I don't expect to see an increase by more than, let's say, the least significant change for a DEXA scan with 1 year. So if I'm just focusing on that, maybe at 1 year, but more likely at 2 years.
Okay. Thank you. This is a very quick question about romosozumab. Vincent Fung has a patient treated with the romosozumab who subsequently developed calcium oxalate stones, major stones, and calcium phosphate stones, and was wondering if you see this as a common side effect or have heard about it with romosozumab treatment.
That's a very interesting question. I have used romosozumab in a handful of patients. Some of them I actually used it because of hypercalciuria. They needed some anabolic agent, and I was concerned about using a PTH analog with hypercalciuria. Now, in my 5 patients in whom I've measured urine calcium before and after romosozumab, there was no increase in urine calcium. So, and I have not seen increased stone risk myself. I'm trying to remember in the large romosozumab trials, there was no mention of kidney stones as an incidence, greater incidence with romo versus placebo or alendronate. So I'm not sure if your patient is unique or has started taking calcium supplements with romo and that's what drove the stones. I'd be curious to look at her urine tests.
I might go to Marcy Shafet's second question because that's a quick one and we might end there. And apologies if we didn't get to your question. There's just so many of them, which is a testament to your talk. Marcy asks, is calcium citrate less likely to cause calcium stones than calcium carbonate supplementation?
So I think so. There's been a couple of head-to-head studies physiologically that looked at change in serum calcium, change in urine calcium post-dose, and the serum and urine calcium excursions are less with calcium citrate than with calcium oxalate when using the same dose. Now, keep in mind, in clinical practice, calcium citrate also comes in lower amounts of calcium per tablet, so that's also relevant.
Right. Thank you so much. I think we can end our Q&A session there, and I'll hand it over to Elizabeth to close. Thank you very much.
Well, thank you very much. I would really like to thank Professor Maalouf and Dr. Khanjee for this excellent presentation. I think we learned a lot. There were still questions left, so there is much interest, and I think it also gave really practical information how to analyze and how to deal with kidney stones. I would like to point out that we, of course, have a next clinical case workshop scheduled already. So please mark in your agenda May 19th of this year. There we have Dr. Priyam and Dr. Lee with a presentation, a clinical case, and background information on the impact of bone and or mineral disease on oral and craniofacial structures. So I I would really like to close this very nice session. Thank all the attendees and the ASBMR for facilitating this, and hope to see you at our next clinical case workshop. Bye-bye.